Welcome to tonight's webinar, MRI for GPs, Considerations and Common Cases. We're delighted to have you here. I'm Tracy Wall from the IMED marketing team. Before we begin, we would like to acknowledge and pay our respects to the traditional custodians of the land on which we meet, past, present and emerging. IMED Radiology takes pride in being Australia's preferred imaging provider, responsible for 1 in 5 diagnostic scans. As we continue to grow, we have improved our support for delivering high-quality patient care. For instance, did you know that using an e-referral results in patients booking their IMED appointments 4 times faster compared to printed requests? This means quicker follow-ups and better healthcare outcomes. Visit our website at imed.com.au to learn more about the advantages of e-referral. Tonight, we are fortunate to have Dr. Samanta Sylva and Dr. Rafal Grabinski, IMED radiologists, presenting on considerations and common causes cases of MRI in general practice, as they will discuss the commonly imaged regions of the shoulder, knee, and the brain, and the benefits that MRI imaging can provide. Before we begin, I'd like to address a few housekeeping matters. This educational event is being recorded and will be available on our website, imed.com.au, alongside our other webinar recordings. You will receive a certificate of attendance via email, and if eligible, CBD points will be logged on your behalf. Lastly, we value your feedback, and it helps us to improve our educational efforts. Please stay on the line at the end of the webinar to provide us with your thoughts. Now, without further delay, I'd like to formally introduce tonight's first speaker, Dr. Samanta Sylva. I'll hand her over to you now. Thank you.
Thank you, Tracy, for the introduction. Today, I'm going to talk to you about some of the things that you need to consider as general practitioners when requesting MRI scans for your patients, some of the safety issues and contraindications, and after that, we will be discussing some case studies. So I will be talking briefly about what MRI is, some of the safety considerations and contraindications, difference between 1.5 and 3 Tesla MRI scanners, a little bit about Medicare licensing and regional deregulation, about Medicare rebates and why we sometimes charge gaps, about contrast media in MRI, and then we will follow it up with some case studies, after which there will be a Q&A session. So a brief introduction about MRI. In MRI, we use a magnetic field to produce images. Without going into advanced physics, just a brief introduction. We use the hydrogen atoms in the body to produce an image in MRI because it's abundantly found in the body, both in fat and water. The MRI scanner has a strong permanent magnet. So when the patient is put into the bow of the MRI scanner, the hydrogen nuclei in the body align in a certain way. Then we apply a radiofrequency pulse, which will change the direction of the hydrogen nuclei. And when the pulse frequency is changed, they will return to the original position, thus emitting a signal. This signal is used to produce the images. So in MRI scan, there is no ionizing radiation involved, unlike in CT scans and plain radiographs. MRI scans also give much better soft tissue resolution compared to CT scans. And what are the safety considerations and alerts and contraindications for MRI? Because the MRI scanner uses a magnetic field, any metal in the body is a cause for concern. So any history of welding, grinding, or sheet metal work, it's important to put in your referral forms so that we know and we can protocol the MRI scan appropriately. Then any implanted devices such as cardiac pacemakers, artificial heart valves, stents, cochlear implants, aneurysm clips, etc. are also concerns. So if you have any information about these devices, it's important that you inform the radiology practice about the device. A common scenario that we encounter is when we have to do an MRI scan for a patient with a cardiac pacemaker. Some of the older pacemakers are deemed MRI unsafe, but the newer pacemakers are what we call MRI conditional. That is, in certain situations and in certain MR environments, they may be safe. So some of the new pacemakers may be safe with a 1.5 Tesla MRI scanner, whereas they may not be safe with a 3 Tesla scanner. So if you know any information about the brand, the type of the pacemaker, or if there are MRI safety aspects, then it's important to let us know. Also, if we decide to go on and do MRI scan for a patient with cardiac pacemaker, they might need pacemaker settings checked by a pacemaker technician before and after the scan. One of the main concerns with a pacemaker is the risk of cardiac arrhythmias and also migration of the pacemaker leads. Then another concern with MRI is claustrophobia, because the bow of the machine is quite small and some people will feel claustrophobic in the small space. So if patient gives such history, if you can prescribe a mild sedative or anxiolytic, it would be useful to take before the procedure. Then what about joint replacements and other orthopedic metalware? Most of these are MRI compatible and do not cause problems when doing the scan, but they may be more prone to artifacts. And depending on the indication, it may be better to do another modality, such as a plain radiograph or a CT scan. So if any information about these things, if you put in the referral form, it will be useful for the protocoling team to assess and protocol the MRI accordingly. Now, this is various machines have various magnet strengths. So the common magnet strengths that we use are 1.5 and 3 Tesla scanners. So a 3 Tesla scanner will have a stronger permanent magnet. So it will give you increased signal to noise ratio. So increased signal will improve the image quality, whereas noise reduces image quality. So increased signal to noise ratio will give you a better contrast and spatial resolution. And the scanning times with a 3 Tesla scanner will be shorter. But having a stronger magnet does not necessarily mean a better outcome for the patient, because some of the 3 Tesla scanners are more prone to artifact. And also some patients with MR conditional pacemakers may not be suitable for a 3 Tesla machine. Then a little bit about Medicare licensing and regional deregulation. A Medicare license is what we call a fully funded MRI. Is a scanner where if you do eligible Medicare eligible service, the patient will be eligible for a Medicare refund. So we have partially funded, fully funded scanners, or non-licensed scanners. So in a non-licensed scanner, patient may not be eligible for a refund and may have to pay more out-of-pocket charges. And from November 1st, 2022, the government changed regional requirements for MRI scans. And according to the modified Monash Area 227, the MRI scanners that are located in the regions are eligible for Medicare rebates, irrespective of whether they are licensed or not. So any eligible MRI scan performed in one of those scanners, the patient will be entitled to a Medicare rebate. And why do we have a mixed billing policy? Depending on the practice and type of the scan, the patients may have to incur out-of-pocket charge. This allows us to cover increasing costs linked to inflation and supply chain issues, and also help us maintain a broad range of specialist services and expertise, and also will help us deliver a truly comprehensive service with the latest state-of-the-art scanners. But if the patients are, for instance, pension card holders or concession card holders or having financial hardship, we would be able to, on compassionate grounds, grant concessions and maybe charge a reduced cap. So if you put in your referral form such history, then we can accordingly charge the patients. Then about contrast medium in MRI, we use gadolinium-based contrast medium for MRI, and they have a very small risk of allergic reactions. The risk of allergic reactions is similar to what we use for CT scans. So iodinated contrast medium and gadolinium-based contrast mediums have similar risk profile. Most of the reactions are mild, and with gadolinium-based scanners, the risk of immediate reaction is about 0.5%, so quite a low percentage, and most of these reactions will be mild urticarial rashes. More severe reactions are quite rare, with a documented death rate of 1 in 5.26 million contrast doses over 10 years, which is extremely small risk. The other adverse effect of gadolinium-based contrast medium is nephrogenic systemic fibrosis, which is not common with the newer gadolinium-based contrast agents that we use nowadays, and it is almost exclusively seen in patients with renal failure. And there's also recent concerns about gadolinium deposition in tissues, particularly in the brain, where the deposition can be seen in dentate nuclei and areas of basal ganglia. Although these have been documented in literature, adverse reactions as a result of this deposition is not seen or not documented in literature, and they are of doubtful effect. What about contrast media in pregnancy and small children? So as with any other medications, we use gadolinium-based contrast media extremely cautiously in children and pregnant women. And usually we do a non-contrast MRI scan, and the images are reviewed by a radiologist, and contrast will be only given if it is absolutely necessary. So this holds true for MRI scans or CT scans or any other modality. Don't order a wrong test because just because the patient requests it, or if it is bulk billed, or if you think you can get it done sooner. For instance, if you have a patient after trauma who's complaining of knee pain and you are suspecting an internal derangement, there is no point doing an ultrasound scan which only images the superficial structures, and with ultrasound you can't see the internal structures. So MRI scan would be the most appropriate modality for this kind of patient. So don't order an ultrasound scan just because you think you can get it done earlier, or if it is bulk billed. In the end, it may cause delays in diagnosis, and sometimes if you order a wrong test, it may unnecessarily irradiate the patient, and in the end, it might cost more when you do the more appropriate investigation. So the next two slides are about the indications for MRI where a rebate is available for adults and children. So if you take adults, the rebates are for limited indications only. So for MRI of the brain, patients with unexplained seizures, or where you suspect intracranial pathology in a patient with unexplained chronic headache, there is a Medicare rebate available. And for cervical spine, it is for trauma or radiculopathy. In adults, for MRI scans of the knee joint, Medicare rebates are only available from 16 to 49 years, and where you are suspecting after trauma, meniscal tear or ACL tear. For any patient above 50 years old, will not be eligible for a Medicare rebate and may have to undergo higher out-of-pocket costs. For children aged 16 years and younger, more extensive indications are available for Medicare rebates, including scans of the hip, elbow, and wrist, where you suspect fractures, or sometimes when septic arthritis is suspected, and for MRI of the knee. Okay, now let's get into some of the cases. So the first case is cervical spine MRI and a CT scan of the same patient. So you have two corresponding images, the MRI scan on the right-hand side and the CT scan on the left-hand side. If you look at the MRI scan, you can see a disc bulge at C5, C6 level, where the red arrow points, and the bulging disc and the posteriorly displaced posterior longitudinal ligament are clearly seen in the MRI scan. But if you look at the CT scan next to it, you can hardly see the bulging intervertebral disc. You can only see some small osteophytes arising from the posterior vertebral body. So the MRI scan, as I said, is much better for soft tissue details, and you can see the disc bulge much more clearly in the MRI scan. And this is the same patient's MRI axial image of the same level, where you can see right paracentral disc bulging, which causes slight flattening of the spinal cord on the MRI scan. In the left-hand side, the CT scan, the bulging disc is hardly visible and you cannot see any details of the spinal cord or any compression. So sometimes after chronic compression, you can see changes in the spinal cord, such as edema or atrophy, where we call myelomalacia. These kind of changes are only seen in MRI scans. Next case is similar, where you can see a disc bulge at L5-S1 level in the MRI scan quite clearly, but it's very difficult to see in the CT scan. This is partly because of increased noise due to large amount of overlying soft tissues in the CT scan. And if you look at the axial image of the same patient, you can see the bulging disc in the right paracentral region, which causes posterior displacement of the nerve roots. So if you look at the MRI image on the right-hand side, the black dots you can see are the nerve roots, which are displaced posteriorly and stretched over that bulging disc. None of these details are available on the CT scan. You can vaguely see the bulging disc where it is pointed by the arrow, but you cannot see details of the nerve roots. Next is a patient with infarctions in the brain. Now, there is no Medicare rebate if you suspect infarction for an MRI scan, but some of the chronic infarctions or small infarctions are much better seen in an MRI scan compared to the CT scan. A territorial acute infarction may be visible in a CT scan, but if you look at this small infarction in the left corona radiator, it is hardly seen in the CT scan. This is the same patient at a lower level. You can see an acute infarction in the left insular lobe. So the infarction is seen as a bright spot in the MRI image, whereas in the CT image, you can't see any difference in that region. Next patient presented with chronic headaches over several months duration. So the patient has indications for a MRI brain, which is Medicare rebatable. There is a CT scan done prior to the MRI scan, which shows a subtle area of reduced density, this black area denoted by the red arrow, in the left frontal lobe. So this appearance is quite non-specific and could be due to an ischemic change or a neoplasm. So the patient underwent MRI scan, and the MRI scan shows a space-occupying lesion in the left frontal lobe, which is white on the T2 image at the top right-hand corner. More difficult to see in the T1 weighted image in the bottom right-hand corner. And in the bottom left-hand corner, we have a diffusion weighted image, which does not show any changes. So this is not in keeping with the acute infarction. So this turned out to be a low-grade glioma. These lesions don't usually enhance with contrast. So in the CT scan, there may not be any enhancement. Next patient presented with acute intracranial hemorrhage in the right frontal lobe. So initially a CT scan has been performed in the acute phase, which shows the parenchymal hemorrhage in the right frontal lobe. And if you look carefully, just posterior to the hemorrhage, you can see dense material filling the anterior horn of the right lateral ventricle. So there is intraventricular extension of this hemorrhage. But further anteriorly in the anterior frontal lobe, we can see some calcification. So this is unusual, and the differential includes bleeding into a calcified neoplasm or alternatively some sort of a vascular malformation. So the patient went on to have an MRI scan, which shows the hemorrhage in the right frontal lobe. But more anteriorly, next to the falx, you can see signal voids which are rounded and elongated, which is quite typical for a vascular malformation. The bottom image is a MRA, which shows the abnormal vessels of the vascular malformation quite clearly. So you can do a CT angiogram. Sometimes we do CT angiograms in the acute phase for hemorrhages, mainly to look for aneurysms, but the nidus of the malformation is much better seen on an MRI scan. Next patient has a lesion in the left cerebellar hemisphere. So we have a pre-contrast or a plain CT of brain on the left-hand side and a post-contrast image on the right-hand side. So the lesion in the left cerebellar the post-contrast image is on the right-hand side, and the lesion in the left cerebellar hemisphere is non-enhancing but calcified. So this has the appearance of a cavernoma, but since this is much better seen with MRI scan, we have gone on and done an MRI scan, which shows the blooming artifact coming from the hemorrhage and calcification, clearly seen in the susceptibility weighted image on the left bottom corner image. So the left bottom corner image is the SWI image, which shows a black area in the left cerebellar hemisphere, showing what we call the blooming artifact. This is a typical appearance of cavernoma. And if you look at the bottom right-hand corner image, which shows the post-contrast T1 weighted sequence, the lesion does not enhance. These lesions are also angiographically occult. So if you do an angiogram, either a catheter angiogram or a CT or a MRI angiogram, the lesion will not have any abnormal vessels seen. Next patient is a 40-year-old female patient who presented with chronic headaches and had an MRI scan, which shows a lesion right at the vertex of the brain in the left parasagittal region. So we have the T1 weighted image on the top left-hand corner and the post-contrast T1 weighted image on the top right-hand corner and the T2 weighted image at the bottom. So the lesion shows quite avid enhancement, and it is what we call an extraaxial lesion, that is, it's located outside the brain. And if you look at the post-contrast image on the top right-hand corner, you can see some enhancement of the adjacent dura. This is what we call a dural tail, and this is a typical appearance of a meningioma. Meningiomas also cause hyperostosis of the bone. So if you look at the orange arrow, you can see thickened vertex of the skull, which shows hyperostosis. So those are the brain and spine cases. Now I will hand over to Dr. Grabinski for the rest of the cases.
Good evening, everyone. My name is Rafal, and I'll be going through the musculoskeletal component of the talks. Also, feel free to send any questions for a Q&A at the end via the chat. So the first case is a 25-year-old patient who had lateral knee pain after a fall, and his initial test was an X-ray. And with the X-ray, you can see that he's had an ACL reconstruction, and pretty much everything looks pretty good. But on examination, he was still locking and unable to play any more sport. So he obviously went on to have an MRI. And so with the MRI, you can see a lot more going on with the joint. So from a relatively normal appearing X-ray, you've gone into a situation where you can see multiple abnormalities. So the first abnormality you can see here is that on the first image is that his lateral meniscus has a tear that couldn't be visualized on the X-ray. And then on the images more centrally, you can see there's a large displaced flap, and that would be in keeping with what we call a bucket handle tear. So this patient unfortunately had a tear of his lateral meniscus, which is flipped on itself into the central joint with a large fragment, and this fragment is causing his knee to lock. You can also see the ACL itself, and you can see that it's intact. The actual graft's intact. So and you can also see on this image here, you can see with those arrows that flipped meniscus that's causing the patient to lock. The second case is another patient who's also had an ACL reconstruction, who's also a 30-year-old, and once again, and he has anterior knee pain, and on his X-ray, there's not a lot to see. His bony structures look normal, and the screw looks fine. And so he went on to have an MRI, and this demonstrates once again how much more you can see with the MRI, with this area of arthrofibrosis seen anterior to the graft, which the arrow is pointing to, and this would be called a cyclops lesion and can be problematic for patients with ACL reconstructions. Now, with MRI is really, really good at looking at the cartilage of patients, and a lot of the pain patients have can come from the cartilage as well. And this MRI demonstrates patellofemoral joint osteoarthritis very, very well. You can see that the cartilage is completely worn in this patient, and there is subchondral edema and cystic change. So for most patients with knee pain, the majority of things that cause pain for the patients are actually intra-articular, and those would be the cartilage surfaces where they become worn, meniscal tear, ACL and PCL tears, and MCL tears. And all these structures are far better assessed with MRI. And a lot of these structures are not assessed at all with ultrasound. So cartilage wear and meniscal tears and ACL and PCL structures are not assessed with ultrasound. So for a lot of these patients, sometimes, I mean, an X-ray is not unreasonable following a trauma, but if you suspect internal derangement, you really have to consider going straight to an MRI in those cases. But I would say that in most cases, an X-ray to start with is not unreasonable because, especially for older patients, if you see degenerative changes in the X-rays, this probably would hold off an MRI. However, in a younger patient who's got pain with a normal appearing X-ray, you probably will need to have an MRI. So here's another patient who had a shoulder dislocation, and this case is shown to show the differences between between CT and MRI. So on the CT, you can see there's a defect in the humeral head, and that would be keeping of a Hill-Sachs deformity, and that's commonly seen in dislocations. And in the patient on the MRI, you can see that defect as well. But associated with dislocations, patients commonly have Bankart lesions, which is an injury to the anterior inferior corner of the glenoid and the labrum in this region. Now, these two images show in quite good detail some of the differences between MRI and CT. So on the CT images, which is the image on the left, you can see the small bony fragment of the displaced bony Bankart lesion, which is actually relatively obvious on the CT. On the MRI, though, it's not that easy. This is the same patient. It's not actually that easy to see the MRI, the bony fragment. However, you can see the labrum very, very well. So this demonstrates that with MRI, you can see the soft tissue pathologies much better than on CT, where you can only see the bony pathologies. And in this case here, you can see the patient's got an anterior labral tear and a bony Bankart lesion. Now, here's the next case is another patient who's a young 20-year-old who has shoulder joint instability and pain, and he's also got a labral tear. Now, this is a slap tear where you can see the arrows pointing to a paralabral cyst in the superior joint, and there's linear signal extending through the superior labrum. Now, a slap tear can only really be diagnosed on an MRI or a CT arthrogram, but we don't really do those anymore. Now, this brings up the issue of young patients with instability, which is a common problem. So some patients, like the first case, actually have had a dislocation event. So it's quite obvious that they've got that they need an MRI to assess the labrum and ongoing instability. But many other patients sometimes don't have as strong a history of trauma, but do have ongoing symptoms of instability. Previously, we would actually do MRI arthrograms to look at the labrums and injuries here. But with the newer magnets, we've moved away from that. And we can actually get away with non-contrast MRIs now for these pathologies. And it's actually relatively uncommon now to need to do MRI arthrograms, although we do occasionally do them. As you can see with these images, most of them are fine. You can see all the pathologies generally. Now I'll go to the next case. So the next case is actually a very common pathology. So this is a 40-year-old female who started developing quite restricted range of motion. And in particular, she had real difficulty putting on her bra. On examination, she couldn't externally or internally rotate properly. And when she abducted, she blocked. So this case went straight to MRI. And on the MRI, you can see florid signal hyperintensity in the rotator interval, which is the top arrow, and diffusely through the inferior glenohumeral ligament. And so this would be a case of adhesive capsulitis. Now, this is actually a condition that doesn't generally need to go for an MRI. So in this case, a lot of the patients would actually get an X-ray and an ultrasound to start with to make this diagnosis. Now, on ultrasound, there's generally not a lot to see with adhesive capsulitis, but the ultrasound is more done to make sure the patients don't have a rotator cuff tear or any other pathology to account for their presentation, because adhesive capsulitis is a relatively clinical diagnosis. But occasionally we do go to MRI to make the diagnosis, and this is what it would look like on the MRI when we do them. But fortunately, these patients respond well to treatments such as hydrodilation, so they do pretty well. Now, this case here is another case of adhesive capsulitis, but this is actually a case where it's become chronic. And what happens when it becomes chronic is that rotator interval actually scars up and becomes very thickened, and the inferior glenohumeral ligament also really scars up. And in these cases, the patients, you can also demonstrate this on MRI, but it's not as florid as the previous case. But these patients generally also respond pretty well to hydrodilation. Now, MRI of the shoulder can also be really, really good at assessing, looking at the joints for other pathologies. So this is a pathology where you can see on this X-ray there's severe degenerative change in the shoulder joint with basically bone-on-bone articulation. And it could look like a normal osteoarthritis. However, when you do the MRI, you can see multiple erosions and large effusion and diffuse thickening of the synovium. So this patient actually has rheumatoid arthritis destroying their joint. And so it can help with the differential diagnoses as well. And you can get a much better assessment of what's going on and narrowing your differential diagnosis. So now we're going to go, Sam's going to take over for some questions regarding MRI and CT, and we'll have Q&A after that.
Right, just a few questions. The first one is quite easy. It's a true and false type of a question. CT is better for evaluation of bony structures, true or false. So you can answer the question by pressing the appropriate button, and I'll give you a few seconds. Okay, so we have 93%, almost 93% answering true, so which is the correct answer. So CT is better for evaluation of bony structure. Although in MRI, you can see bone edema, which occurs with fractures, but CT with its better contrast resolution will show small hairline fractures even. So CT is better than MRI. So the next question is, MRI is better for evaluation of soft tissue structures, true or false? Again, I'll give a few seconds to answer the question. So 100% answered true, which is the correct answer. So MRI is better for evaluation of soft tissue structures. So next question is a bit more we've got a bit more complicated. So each question you have to answer true or false. So the first part is information about the brand, type, and number of pacing leads to check MRI compatibility. Second is pacing technician to check the setting of the pacemaker before and after the MRI scan. And third is cardiac arrhythmia is a potential complication. So for the first question, about 45% have answered as true. Let me just. So all three answers are true, in fact. So information about the brand, type, and number of pacing leads to check compatibility is true, and MRI pacemaker pacing technician is usually needed to check the settings, and cardiac arrhythmia is a potential complication. So for the first one, about 40% have answered true, and second one about 30%, and third one also about 30%. So next question, which of the below are MRI rebatable? So 50-year-old with chronic headache, 20-year-old with unexplained seizure, 51-year-old with acute knee injury and suspected meniscal injury, 35-year-old with 2 weeks of neck pain post-MVA and suspected ligamental injury, 70-year-old with neck pain and suspected radiculopathy, and 40-year-old baseball player with suspected microinstability of the shoulder. So each question has a true or false type of answer. So of the answers, the 51-year-old with acute knee injury and suspected meniscal injury is false. They cannot, that service is not Medicare rebatable because of the age. And for MRI, there is no Medicare rebate. MRI shoulder, there is no Medicare rebate. All the other answers are correct. So that's all the questions. And now we can take some questions and try to answer them.
So I'll sort of be chairing the questions, but I'll share the questions between myself and Sam. So I'll start with the first question to Sam. So Sam, first question we got is, for MRIs that attract MBS rebates for GPs, is there a time frame before we can repeat the studies? For example, for echo, we can only do them every 2 years if indicated.
As far as I know, they don't specify a time period. But I think a reasonable period of time, depending on the indication, would be necessary.
Yeah, my understanding as well is that there is no time limit. There is no time limit. But in general, generally, once a diagnosis is made, it's not usually required. A second MRI is not generally required very soon after. In most clinical indications. Now, Sam, the second question we've got is, how long does the average MRI scan take?
Right. That Also depends on the type of the scan, but most scans we take about 20 minutes of scan time, and some scans about 30 minutes. So, but I think most of them are around 20 minutes duration. So they don't take that long.
So we've had another question here, which there's actually two questions which are similar, but the first one is plain X-ray still recommended, or should we refer to straight for MRI for knee pain? And connected with that is ultrasound of the knee ever appropriate with investigating knee pain? And these two questions actually are connected. It really comes down to the clinical, I'll take this question. It really comes down to the clinical scenario. So really X-ray is very useful in two settings. The first one is in trauma. It's very useful for assessing for fractures. It's easy to do and it's accessible. And so if you suspect that a patient may have some trauma or may have broken something, it is definitely the best test to start with. And that's in the community and in the emergency setting. In the community also, but also in patients with pain, the setting of an older patient looking for osteoarthritis, X-ray is still very good, because if you do an X-ray on a patient and they have bone-on-bone articulation, the MRI is not going to add much more value to that. I mean, the diagnosis is effectively made there, and you could almost tell what the MRI is going to show just by looking at the X-ray, that there's going to be macerated meniscal tears, there's going to be a joint effusion, there may be a couple of small loose bodies. So for those cases, I'll probably just start with an X-ray for the degenerative knees, and unless the patient's got some more significant symptoms such as locking. Now, so X-ray is useful to start with, and it's not unreasonable, but in general, when X-rays are normal or don't show much, as we saw earlier, that's when you jump onto MRI. And also MRI is less accessible and much harder to get generally. And then, so therefore, for most patients, an X-ray is not unreasonable to start with, and then go to an MRI. And some pathologies are actually easier sometimes to see on X-ray and see, especially some of the bony ones, where because MRI is actually quite poor at looking at some of the bony structures, and also relatively poor at looking at calcium. And some conditions such as calcific tendinopathy can be hard to see. Now, the second question to that was, is ultrasound ever appropriate for investigating knee pain? The answer to that one is, ever is a strong word, but yes, there are a couple of occasions where ultrasound can be useful in managing a patient with knee pain. If you're worried that a patient has a Baker's cyst and that their pain is from a Baker's cyst, then an ultrasound can be very useful, because you can see the Baker's cyst and it can be very useful, and you'll see it straight away, and then we could even drain it if you wanted to. And so it is actually useful in that setting. It's also useful in assessing the patellar tendon and looking for patellar tendinopathy, and also quadriceps tendon tears. So those are two scenarios that they would be relatively useful at looking at. But the moment you're worried about chondral wear, meniscal tear, ACL injury, it's not going to help you. And we would discourage it in those settings. It's almost invariably, at most times it just shows an effusion, maybe an MCL sprain, but really there's a whole game going on behind the scenes that ultrasound's not appreciating. So I'll be hesitant in really using it outside of looking at the patellar tendons and looking for Baker's cysts. Now, the next question we've got was, is there a weight limit for MRI in terms of patients? So this has actually become a big issue in America, because obviously they've got a lot of big patients. I think we've got a lot of big patients here as well. So they've started, so basically the standard magnets, there's two issues. The first one is the weight. And for most standard MRI magnets, it's about 150 kilograms would be a standard MRI weight, up to 180. One of the issues, though, is that a bore of the magnet can be quite tight. And if you are very, very large and very, very round, you might not actually fit through the bore. So even though you might be within the weight limit, if you're sort of very short and very wide, you still might not actually fit in the magnet. And so that's pretty much the standard magnets. Now, there are what we call wide bore magnets, which have actually been designed specifically for very large patients, over 160, 180 kilos. The weight limit on those is 250 kilos, but those are pretty uncommon. But there are MRI scanners that can do those weights up to that sort of level. So yeah, and so if that answers that question. And just looking at the other questions, there's a question about knee replacements and MRI. Now, which is also a good question. With most replacements, there's a real issue with metallic artifact with any replacement. And basically, it causes, when the magnetic field goes through when the images are acquired, there's a lot of what we call blooming. So the metal causes a large amount of black signal around the joint. So it actually distorts most of the structures around it. That said, you can still sometimes see some pathology around the prostheses and replacements, and it can sometimes see conditions, particularly things like particle disease in hip replacements. MRI can actually be pretty good at looking for the synovitis and the particle disease process eroding the bone around the bone, so eroding the bone, and or any collections associated with that, and it can look for soft tissue structures around it. The question we have here asks particularly in the knee. Now, in the knee, MRI can see what we call arthrofibrosis. So some people who have knee replacements get this really severe fibrosing condition where the actual whole joint just fibroses. And you can see that on MRI, even allowing for the distortions. And we do use metal suppression software that suppresses the metal signals and tries to make it easier to see. But you can occasionally see pathology, although it's relatively difficult. So we do them for replacements, but it's a bit hit and miss for that. So I think that's all the questions we have time for. So I hope you enjoyed the talk. So I'm just going to hand over to Tracy to finish the talk.
In conclusion, I would like to express my gratitude to Dr. Samanta Sylva and Dr. Rafal Grabinski for their insightful presentations. I also extend my thanks to our audience for joining us. We eagerly await your feedback, so please stay online as you will soon be redirected to complete your evaluation. Stay safe, stay well, and have a great night. Thank you.